Good morning, everybody. I'm Elisabetta Abruzzese, and I will present this real-world outcome of pregnancy in CML, also on behalf of Ekaterina Chelisheva, which is sharing with me the real-world registry of pregnancy in the CML. In the past 10 years, this subject has acquired growing interest in the scientific community, and special knowledge has been obtained from bench to bedside. Embryological, pharmacological, and pathophysiological studies have merged with worldwide patient database to provide a roadmap to a successful pregnancy and birth in CML patients. Discussing only the past 5 years pregnancy series that have been presented, as you could see here, a few studies have presented on male CML, and a little more studies have presented in female CML patients. This because, as you all are aware, female patients have to carry the baby, and usually they cannot stop the treatment unless some particular situation of very deep molecular response and safe TFR. Different subjects have been addressed. As you could see here, recently a work from Indian group on unplanned pregnancy has been published. Some other work also from India have been presented on both male and female patients on treatment during pregnancy. We presented a single center work on 11 pregnancies in male patients and 30 female patients. And we studied also the therapy and the placental crossing. Another big group of patients has been presented by Essie et al., and it was more concentrated on the CML outcome, pre and post pregnancy, and so on. The first actually observational study in order to do a registry in adult patients with chronic myeloid leukemia treated with tyrosine kinase inhibitors has been set on 2012 and has started on 2013. So this year it will be 10 years that this registry is going on. This because, as you could seen in the previous slide, most of the reports were case series from mainly single centers. So when we realized that CML was not anymore this deathful illness, but it could be treated as patient, as in real they are, will have a normal survival when correctly treated and responding to the illness, the idea that they could want to pursue a family desire has become mandatory, and more the doctors have been questioned about it. So in 2013, we started this registry that was both retrospective and prospective, observational, and whose primary objective was to describe the observed population in terms of pregnancy and conception outcome, both on male and female patients. The addressed questions were mainly three. The first was pregnancy related, and it addressed the type of conception, the abortion rate, the pregnancy progression, the delivery, and the breastfeeding. The second was, of course, CML related and concerned the therapy of CML before, during, and after pregnancy, the transcript kinetics movements during pregnancy, and the outcome of the mother's post-delivery concerning CML. And the third is baby related, and it referred to birth, psychomotorial development, language, school. Those results were divided into 4 groups, 0 to 3 years for the first psychomotorial development subject, 3 to 6 years, language and socialization, 6 to 12 years for knowledge acquired in school and school performances, and more than 12 years for puberty and sexual development. These are the participating centers in Italy of the trial, the CML 1012. And the last update that was done on February, 195 pregnancies and conception were registered, 109 male and 75 female. Those are the pregnancy information that we have generally. The age of mother at conception was a median of 33 years, both for female partners of male patients and for female patients. Most of the pregnancy were planned, while the pregnancy type were mostly spontaneous, but we also registered 5 medical induced pregnancy in male patients and 7 also in female patients. There were also 2 spontaneous conceptions in male patients after allogeneic bone marrow transplant. Overall, the results are the following. Abortion were 15 out of 200, and there were mostly spontaneous abortion that occurred during the first quarter of pregnancy and were not related with known congenital malformation or genetic defects. No therapeutic abortion were registered. Also, the complications during pregnancy were comparable with the general population. Type of delivery, as expected, was a little more cesarean section for female patients compared to female partners of male patients, even if, as you could see in the male group, the percentage of cesarean in the female group was not so high compared to the general number of cesarean section in Italy that is quite high, is approximately 1/3 of the delivery. The week of delivery was also quite normal, the median of 40 for male and 39 for female. Breastfeeding, of course, was very little, 21% for female patients, but is growing. And the therapy during pregnancy was necessary in 15 out of 84 female patients. Most of the patients were treated with interferon, while 3 patients were treated with TKI. And we'll see later on when TKI can be introduced during pregnancy for the treatment of female patients. The outcome of babies was good, with minor problems reported. And we have recently presented an abstract at ASH that we hope could be selected, and so more information about babies will be probably disclosed in this occasion. Parallels to the GMEMA study, we thought that it was important to cross the borders of Italy, and we presented the study in the European Leukemia Net group. At the same time, Ekaterina Chelisheva has set another similar database in Russia, and so we decided to merge our knowledge and to start a registry with a collaboration of all over the world, not only European countries. And those are the countries that have contributed to the cases, 17 countries for 19 sites, for a general outcome on information of 400 outcomes. The registry of ELN is concentrated only on female pregnancy cases, so it's more direct to the female population. And of course, it's important that this encompasses different countries because of the different cultures, the different age of presentation of CML, and also the different way and the drugs that are available are very important in understanding how to manage this important subject. The total number of cases has been reported for 298 females, and of course you understand that there are more pregnancies because one patient could have had several pregnancies. And there were 86 cases of CML onset during pregnancy in 11 countries. And this is a very important subject because as we can see, the diagnosis of CML that can be done during pregnancy is a complicated and difficult situation to afford. And thanks to this registry, 86 patients could be studied, and we'll see shortly the outcome of those patients. For what concerns pregnancy after CML diagnosis, we have a total of 314 cases for 249 cases of pregnancy that were continued and 249 childbirth. These are the information. Of course, the registry is not completely updated and we don't have complete data for all the patients, but this gives you an idea of the numbers and the outcome. So if you could see here on the 314 patients, 79 ended up in labor and childbirth, while 13 patients were decided to stop pregnancy, and 6% of those patients presented with a spontaneous abortion. And also here, you can see that with a larger patient population, the percentage of spontaneous abortion is completely below the range that you have in the general population, that is about 10%. There were 32 babies that were born preterm, but most of the babies were born at term. And also here you can see that 50-50 is the percentage. No, I'm sorry, that is a little more high, the percentage of spontaneous delivery compared to the cesarean section. Some patients were treated during pregnancy, and at conception, almost more than, I would say more than half of the patients were treated with TKI and stopped the treatment at first pregnancy test as soon as they realized that they were pregnant, while less patients were treated in second or third trimester. One patient was treated in leukapheresis. 13 cases were treated with imatinib for the whole pregnancy. 12 cases were treated with PEG interferon. Oops, I'm sorry. And 7 additional cases of hydroxyurea were used in combination with other therapies. The characteristics of the newborns were quite normal, also for babies that were treated, patients that were treated with TKI at the end of pregnancy during second or third trimester. If you can see the full-term birth for patients that were not treated, were 87%, with interferon 82%, and with TKI 79%. So it seems that a very little percentage of patients treated with TKI were born preterm. But here you must consider that probably if patients were treated with TKI, the situation of CML was not so quiet. And for this reason, we need to investigate if these were really babies that were born preterm, and how many of those babies were small for date, or if those babies were born preterm just because we needed to start again treatment for CML, or maybe change drug that was not allowed to be used during pregnancy. Those are the general data of the fully reported deliveries. Male or female ratio of babies' outcome was 1 to 29, but not very important actually. Weighted birth was 3 kilos 250 grams. No birth abnormalities in the majority, while 5% presented with some birth abnormality. But actually, those birth abnormalities were the ones that were usually reported in the general population and didn't seem to be related to treatment or not treatment, either in the first trimester or in the second or third trimester. There was 1 polydactyly, 2 hypospadias, 3 non-closed foramen ovale, some in preterm and some both in preterm babies. And none of those abnormalities were severe or life-threatening. The median age of the children was 5 years, but there was a range between 2 months and 17 years at the last evaluation, and this needs to be updated. Those are data from actually, I believe, 2 years ago. So it's important that we consider that in pregnancy in CML, we need to balance the mother, the baby, and the illness that are all important and mutually related one with the other. The information of the real-world pregnancy on CML is that the male patients can conceive during therapy. Female patients should not be treated during pregnancy, but if needed to treat when, is important to know that we can consider treating to maintain MMR. We need to treat at MMR loss, and we need to treat at a complete hematologic remission loss. The drugs allowed are interferon at any time, imatinib and nilotinib after placental formation. For how long? You can treat the patient until delivery. And the breastfeeding is allowed if on interferon or, of course, on TFR, while fertility preservation needs to be discussed at diagnosis. And on the children's side, we are starting to analyze more in detail what happens. And with the smile of the children that would never be born, probably without collaboration, knowledge, and the help of all the patients and families, I thank you all for the attention.